Hello, my name's Paul Dosey, and I'll be presenting this presentation, Medication Aids, Staffing Shortages, and Maslow's Hierarchy of Needs. Maslow's Hierarchy of Needs is one of the primary priority-setting frameworks of nursing. And here are the 6, and it's usually listed as the first one. And as you can see there, Maslow's Hierarchy of Needs, the nursing process, the ABCs, safety and risk reduction, least restrictive, least invasive, acute versus chronic, unstable versus stable, urgent versus non-urgent. These are frameworks that we're well familiar with, and Maslow's hierarchy is one of the primary ones. Maslow's hierarchy focuses on what motivates people. It is a motivational model, primarily. Maslow's model is holistic. In other words, it focuses on the total person and emphasizes health rather than sickness, or if you will, prevention, as opposed to a problem-centered focus on acute care. Okay? Maslow's basic theory, what drives and motivates the individual, will focus on unmet needs. Obviously, a person who is starving to death is going to be solely motivated by getting food. But once that basic need is met, the individual will focus on the next priority in needs. Hence, self-fulfillment needs are the optimum for happiness and well-being. So the first thing we're going to look at is the staffing side of Maslow's hierarchy. How do we want to use Maslow's hierarchy for a staffing model? Okay. Does the job supply, and we'll go to the bottom of the hierarchy pyramid here, does the job supply an acceptable wage? That comes under the bottom, as you can see, physiological needs like food, water, warmth, rest, good shelter. And then also security needs could be shelter as well. Self-care needs, security, and safety. Belonging and love needs, intimate relationships and friends. That's going to vary in the job or career setting, but it's very important for an employee or a healthcare staff member to feel like they're a respected member of the team. And what we learn in school, nursing school, is that as a aspect of therapeutic communication, we're always to respect other members of the care team. That's very important. Okay. Next, we have a focus on what the team member brings to the table rather than faults. All right, that's esteem needs, prestige, and feeling of accomplishment. And when we implement constructive criticism, we just need to be careful. Overall, it's very helpful if the focus and how you perceive that person is based on what they bring to the table. And most people bring something to the table. Then at the top, is the job leading to self-fulfillment? you know, most people look to be self-fulfilled in their career. It's just not about getting a paycheck to obtain the basic needs down there on the bottom. But it's also very important, equally important, I think in some cases, with many people, more important, that it gives them self-fulfillment or a sense of accomplishment. You're going to want to note over here to the right of the pyramid how these are broken down. The bottom is basic needs, the two bottom. Then the next two are psychological needs, and then self-fulfillment needs. All right. So staffing shortages are the result of really Maslow's hierarchy not being a staffing model or used to obtain employee goals. That is in how the administrators or those who are in charge relate to the staff. Okay, so staffing shortages are the result of nurses and aides in LTC typically perform a fraction of what they are trained to do, continually doing a fraction of what healthcare workers are trained to do is defined by burnout. So, our definition of burnout, per se, should be the failure of the career to give the person self-fulfillment, but in also doing that job, there are maybe a lot of hours worked and a lot of stress leading to no feeling of accomplishment. That's the very definition of burnout and how burnout should really be defined. So, the unfulfillment leads to toxic atmosphere of gossip, complaining, and unconstructive criticism. You see, that's the next down. So, these top three hierarchies are not accomplished. Now, if you look at the two bottom ones, I don't really think that, though those are important to people, I think really, as an older person who has a lot of experience in management, I've got to say that I really think the top three are the most important. And I've seen time and time and time throughout my life, in my various careers, that people are more than willing to settle for lesser pay if it's a job that they like. Okay? When people find their dream job, the focus seems to be that it's their dream job and really not all that much what they're making. Okay? Now, however, if the top three levels aren't accomplished, staff may compensate. There's going to be a compensation. They may compensate by wanting more money, forming unions, or working for the highest bidder, right? Job hopping. The only thing that keeps them where they're at is that the present employer is the highest bidder. They may also attempt to obtain the higher levels through competition against team members. All right. So if if say, the management is hypercritical, is very poor at supplying the top 3 levels, an employee may not quit, but they may attempt to obtain say, the self-esteem level by tearing others down, right? Okay? So when the top 3 aren't supplied, there tends to be negative compensation primarily focused on the lower levels. Regression in the workplace. Unfulfilled needs of the higher levels cause individuals to regress to a lower level of motivation. In the case of an individual operating on the self-fulfillment level, a diagnosis of cancer may cause the person to necessarily refocus motivation on treatment. However, in some cases, the regression of motivation for other reasons may take on negative attitudes and actions. More than likely, faulty staffing models lead to the well-known toxic atmosphere in healthcare. And my contention is that faulty staffing models and theories of therapeutic communication between administration and staff is the if not only the number one reason we get these toxic atmospheres that we get in healthcare. Furthermore, the primary cause is excessive hours performing a small percentage of one's scope of practice, leading to unfulfillment, neglect, and guilt. Okay? So second to these faulty staffing models is, the bottom statement there, performing an excessive amount of hours while practicing a small percentage of one's scope of practice. And that is, like I said on the first slide, is how burnout should be defined. All right, this is sort of an aside, but not exactly. And the right side is what this is based on. The source is Ohio Jobs and Family Services. And they cite in their pamphlet on elder abuse, they cite these 5 types of abuse: exploitation, self-neglect, emotional abuse, physical abuse, sexual abuse, neglect. And what I want to point out here is you see how each one of those types deprives the person of a specific level of Maslow's hierarchy of needs. Okay? Neglect deprives them of physiological basic needs, right? Neglect leading to loss of basic needs such as food, water, and adequate shelter. This can include basic medical care and adequate clothing. Nurse aides can unwittingly, as well as nurses, unwittingly neglect people of this by not having time to make extra effort in encouraging a resident to eat, or not what we call icing the residents, or making sure that their water canteens are full. Especially in long-term care, dehydration's a big deal. Okay? Leads to a lot of problems. poor wound healing, just a lot of different things, right? All right, so physical abuse, sexual abuse, that undercuts the need for safety. Physical force that causes bodily injury, pain or impairment, inappropriate administration of drugs, or other forms of restraint, right? Because of lack of time and lack of staffing, are we medicating people instead of aides fulfilling their role of diversion or companionship, right? As a nurse, I can tell you that at least 80% of the time, if an aide needs or an aide has time to sit with a resident, or take them for a walk, or supply a little bit of companionship, that's enough, usually, when a resident's agitated. Emotional abuse, a need for love and belonging. Isolation for purposes of concealing abuse also includes bullying and verbal abuse that might be assault. Self-neglect, this comes under the need for esteem, can be the result of neglect process with adverse reactions such as poor hygiene, hoarding, and self-harm. A lot of times those are indications of abuse. Exploitation. So here we have a situation where the fruits of accomplishment are taken for the benefit of others. Okay? This might be a little bit of a stress, but I want to point out in assisted living where patients and their families may be paying anywhere from $4,000 to $14,000 a month for care they're not getting, right? Okay? Because of lack of staffing, and that is not a deliberate exploitation, but it's kind of exploitation nonetheless, isn't it? So over here to the left, it is interesting to note that the 5 categories of elder abuse, according to OJFS, directly circumvent each level in Maslow's hierarchy of needs. Wherever needs are not being met, an environment fertile for abuse exists. OJFS cites caretaker stress as a leading cause of elder abuse. So these staff shortages, I believe, beginning with poor staffing models, leads to this downward spiral, right? Okay, this downward spiral. All right. Let's look now to the care side of Maslow's hierarchy. And I want to use nurse aides as the example here because I want to use that to segue into medication aids. From the resident's needs perspective, note the major role that nurse aides play. In fact, nurse aides lay the primary foundation in LTC that all other care and treatments build on. However, how many nurse aides see their role in this light? Again, we have a situation where nurse aides perform roughly 10% of what they are trained to do. This means that their jobs do not supply a pathway to their own self-fulfillment by realizing their full potential. The discipline of medication aid, certified, simply adds another level to which aides can further help nurses realize their full potential through upward mobility. Okay, so if we look at this, nurse aides, and as we want to reiterate, Maslow's hierarchy of needs is a primary nursing care priority, right? And if you look at this, nurse aides all but own this whole venue, all right? While it's the priority of the nurse, the aides are really the ones that make this happen, right? So, I've got a statement, I think, up here. I want to go back to this top paragraph. Note the major role that nurse aides play. In fact, nurse aides lay the primary foundation in long-term care that all other care and treatments build on. So how well the aides perform these foundational levels or hierarchies really depends on how well the nurse can build on that foundation. So obviously, physiological needs like food, water, warmth, and rest, right? The ADLs, we call them, right? Activities of daily living. And then, safety needs. Your good aides are going to put the bed all the way down before they leave the room. They're going to make sure the call light's within reach. They're going to make sure the head of the bed is up in semi-Fowlers because we don't want the residents choking. And then companionship. Now, as a guy STNA, I had to learn about this because I think men tend to be task-oriented. So, when I was first working as an STNA, some of the girl aides would be loving on the residents, hugging them and telling them how much they loved them and this, that, and the other. And I was always like, oh, for crying out loud, please just shut up and do your job, Just the whole task-oriented thing, right? I've come to learn that aides being a source of friendship, and a source of love and belonging to residents is a very real and needed thing. Families just aren't in the picture as much as they used to be. Not only that, just because a family is a family doesn't mean that they have that resident's best interest in mind, does it? Okay, and that may even boil down to the aide needing to be an advocate for the resident, which connects to the level beneath it, which is safety and security needs, right? So, yes, and then esteem needs. Now, for the aide, from the staff side, you can look at this, that, it's very important for the role of the aide and the aide's job to supply them with esteem and feeling of accomplishment. But how well a resident esteems themselves is going to be intrinsically connected with those lower levels: belongingness and love, safety needs, and physiological needs. How well the aide performs and how much they receive as residents, those lower levels, that is what's going to feed the self-esteem of the resident, right? You know, if the aide always makes sure they're well groomed and have clean clothes, and they're sitting out there in the lobby in their wheelchair, and man, as a nurse, I'm just saying, he looks good today, or she just looks good today, okay? And you tell the resident that, and, you know, this is all an esteem builder, isn't it? If the aide is assisting in a meal and is not distracted by their phone and is conversing with the resident and has full attention on assisting that resident with a meal, of course that's going to make the resident feel more important and more valued as an individual, correct? All right. Excuse me. Okay, let's go on to the next slide. All right, so nurse is a noun, aid is a verb in context to what we're talking about, and we're going to get some help from Captain Obvious. All right, Captain Obvious. The nurse aid discipline is an open concession that nurses need help in fulfilling their roles as nurses, leading to self-actualization. In addition, the medication aid certified discipline is an open concession that nurses pass too many pills. And if that is the case, and we all know it is, it explains in totality why there is a shortage of nurses. An open admission that nurses pass too many pills is also an admission that care, other than medication administration, is not being performed. Okay? Can't do two things at the same time. And, you know, if you take into consideration what we learn in nursing school, and, you know, I mean, medication administration is one discipline that we learn amongst many in nursing school. It's not by any stretch of the imagination 80% of the body of information we learn that is supposedly efficacious to being a practical nurse, okay? Therefore, nurses are hindered from performing their roles on three fronts. One, a shortage of nurse aides because their job doesn't lead to self-actualization that it should. Secondly, the nurse scope of practice being dominated by med passes. And third, the subsequent staff shortages of aides and other nurses. All right, this is from Harrington, LPN to RN transitions. Although nurses are making important contributions to healthcare reform and quality care, the loss of nurses from clinical practice to entrepreneurism is contributing to the nursing shortage. As Saba and McCormick noted, recent survey data indicate that a growing number of nurses are qualified as information specialists. Others are assuming such roles as legal nurses, lobbyists, diabetic educators, salespersons of a wide array of products, consultants, business owners, and travel agency nurses. As described previously, bioterrorism, preparedness, and internet-based entrepreneurial opportunities are also growing. Of course, this makes perfect sense, especially in LTC, because aides as well as nurses are only performing a small percentage of what they are trained to do. When one is self-employed, their upward mobility and the self-satisfaction that comes with that is unlimited. On page 144, Harrington and Terry note that increased immigration and appropriate regulation to facilitate this increase into the healthcare system may ease nursing shortages, but this is merely adding numbers to an already failed system that cannot sustain staffing. So, we're just finding ways to add numbers to an already failed system. The key follows. Nurse aides working in accordance to their full scope of practice, which includes passing medications as a higher level of nurse aide, and resulting in a career that meets their own self-actualization needs, will enable nurses to fulfill their scope of practice and their own self-actualization needs. Supplying a career that enables individuals to meet all of their hierarchy and needs will attract the needed numbers of clinicians and will retain them. All right, so we'll call this up the pyramid, okay? When nurse aides are self-fulfilled, that, and you can add to that the upward mobility from becoming a medication aide, which gives them another tool in their tool bag to aid nurses, right? Nurse is a noun in the context that we're talking here. Nurse is a noun, and aid is the verb, okay? This leads to nurses better doing their job and reaching self-actualization in their career. And even though a nurse having, say, whatever's required, 1 or 2 medication aides on her hall, or unit, I should say, and the unit may have 4 halls. So let's say, 2 people are needed to pass the meds, or 2 med techs. So rather than have 2 nurses, now you have 1 nurse and 2 medication aides. So your staffing cost may be what? Maybe 10% higher, okay? The nurse will spend time, will have time to talk to families, may even be able to partake in family conferences, care conferences, right? Wow, that would be amazing. The actual nurse that's taking care of them can participate in the care conference. What a concept. The nurse can then do orders, take phone calls, do the insulin, do the narcotics, and if that's all the nurse is doing, and not passing the primary meds, that frees up a lot of time for her to do everything she's trained for. I've mentioned some of them. But the time to do all of the wound treatments the right way, and really the list goes on and on and on. Like I said, the cost might be what? I don't know. I think 10% would even be a stretch. Probably more like a 5% increase in cost. But here's going to be the results. The results are going to be increased long-term care census in your facility, increased quality of care, decreased cost of care. So when the aides, are being fulfilled in their career, there isn't turnover. And then when you're fully staffed on aides, especially with a full census, now all of a sudden the aides have time to turn certain people, reposition people every 2 hours, keep people hydrated, and all of the things that are preventative in preventing pressure ulcers or whatever it might be. Range of motion, companionship. The list really goes on and on and on. All of this is going to decrease cost of care in the facility demonstrably, not to mention nurses spending less time treating and assessing. And again, you're going to get adequate staffing, and you're going to get patient and family satisfaction. That's going to be the result. The results, which, is going to, dwarf any added expense you would have in a few additional medication aids. Okay? Now, as far as nurses seeing medication aids as a threat to their jobs and career, that's unfounded. There's too much of a shortage of nurses for that to really happen. Now, less nurses will be needed, but that's okay because there's already a drastic shortage. But this isn't going to lead to any nurse not being able to find a job because of medication aids. All right. Now, I think what should be scary to us, very scary to us, is we got to ask why. Why do nurses think they'll lose their jobs because of medication aids? All right. Well, you ready? Here it is. The nurse will say, well, if we have somebody passing most of the medications, what am I going to do? See, that kind of makes the whole point, doesn't it? All right. And unfortunately, we've been not using Maslow's hierarchy of needs as a staffing model for so long that unfortunately, what we discussed a little bit earlier about unfulfilled nurses, floor nurses moving on to other things, that's what's going to happen. And all you're really going to be left with is nurses that are, for lack of a better term, shift nurses, or a more crass way of putting it, they're just clock punchers. Okay? They're just clock punchers. Okay? So, conclusion. The centrality of Maslow's hierarchy. Maslow's hierarchy of needs is a staffing motivational model, a patient care model, and a framework of nursing priorities. It should form the goals for all aspects of healthcare. People not only seek income from their careers to secure the basic needs at the bottom of Maslow's pyramid, but they primarily look to their careers to achieve self-esteem, acceptance and love from others, and ultimately the self-fulfillment of being all they can be. In long-term care, the medication aid certified is the primary tool to accomplish these goals because nurses are dominated by medication passes, leading to the detriment of quality care. Lastly, we must remember that burnout is defined by working hours that fall well short of a nurse's scope of practice. The scope of practice is a standard of care that is determined by the practice of the scope. I hope this is helpful. Thank you so much for listening, and have a great day.